Hello, everyone. My name is Brian Jones, and I'm the membership manager with AVLS. I'd like to welcome everyone to the AVLS Veno-Lymphatic Trivia Showdown and a collaborative approach to treating phlebolymphodema, sponsored by Tactile Medical. Before we get started, a few housekeeping items. All attendees are muted so we don't pick up any background noise during the program, and the webinar will be recorded and posted on AVLS's website. A link will also be emailed to all who have registered for the event.
Welcome everybody. I'm Tony Gasparis. I'm here with Steve Dean, and I want to welcome you to the Veno-Lymphatic Trivia Showdown. So many of you, when you register for this, you were given instructions to download Kahoot. This is the app that will be used if you want to participate in this fun game. We're going to have to try to make this entertaining and for you guys, and I hope we do. If you haven't done so, please download the app. And you can find that either in the App Store or Kahoot.com in order to be able to play the game. Now, there's a chat function in this meeting here, and in the chat function, there's a couple of things that you can do. One is the code that you will need in order to participate in the game. There's also the ability to put questions there if you have, and we'll be addressing those questions either during the show, but usually at the end of each round. A few instructions for the game, and we need to have some slides up from Jenna for this. So there will be 3 rounds, and each round has 7 questions. The top 3 winners for each round will go on to the final single elimination round. And your score is dependent if you get the right answer, as well as how fast you answer the question. So to give you a couple of examples of how the questions will pop up. So for example, this is just, can you name this classic game show? This is just an example, so don't think that you have to answer this question. And once the clue is given to you by Steve, you would pick the correct answer, whether it's The Price is Right, Who Wants to Be a Billionaire or a Millionaire, Hollywood Squares, or Jeopardy. And you can see they're different color-coded and different shapes. Instead of A, B, C, D, you would pick the correct answer. So for this one, obviously, it's Hollywood Squares.
Yeah, Tony, you said clues. I'm not giving any clues here. No way.
Well, don't you have some clues of pictures?
Oh, well, I have photographic clues, but yeah, I just didn't want anybody to think I'm going to be giving anything away here. Sure. No. Sure, I have photographic clues.
So similar to this, this would be a video example of a question. Go to the next slide. We're not getting much voice here, but Steve, you have any idea what this show is?
I have my screen in front of me. I can't even see anything. It's still on my, I'm sorry, I just have my screen here. I mean, as far as the,
well, this is an old classic. I don't know if anybody knows the answer to this one, but this is Password.
Okay, now maybe I can see it. Password, okay.
So just to reiterate again, since some people may have been late getting into this, please make sure you download or have available the app, Kahoot. It's either in the App Store. Hopefully you got the instructions before this event started and you downloaded the app. Or you can go to Kahoot.com for that. And there is a code in the chat room, in the chat section. For the first round, you're going to have you're going to see in the chat room the pin there to enter the game. And to make it clear, for every round, after the end of the first round, after the end of the second round, again, look in the chat room for the next round's pin, and you're going to need that. Also submit your name so that we know who the winner is, or the top 3 winners for each round will be. And those top 3 winners with the highest score are going to go into the final round, which is a single, it's an elimination round. So if you get any question wrong, you're automatically eliminated and go, and whoever's left continues until we end up with the top 3 winners. And those top 3 winners will have a choice to pick one of the journals that are listed in the next slide. You can see JVS, Phlebology, the New England Journal of Medicine, and Lymphatic Research and Biology Journal. So without further ado, for the thousands in attendance and the millions around the world from the virtual world of AVLS, let's get ready to rumble. All right, Steve.
Wow, that's a rousing intro there, Tony. Rousing. All right, so like Dr. Gasparis, I'd like to welcome you to the Veno-Lymphatic Trivia Showdown, AVLS 2020. All right, so let's start off with round 1. And our first question, I'd ask you to identify the cause of the following limb swelling.
Steve, we're not seeing your slides yet. Here we go. Okay.
Okay, let me go back here and we're going to start over again. Okay, so you heard what I said. This is the Veno-Lymphatic Trivia Showdown. We're going round 1 and we're going with our first question. Our first question would be to identify the cause of limb swelling. Is this consistent with lipedema, a venous vascular malformation, pretibial myxedema, or phlebolymphodema? Go ahead and cue in your answers. Five seconds. 2, 1. Okay, well, a clear majority got this correct at phlebolymphodema, but even though despite thousands playing, we only have 14 respondents here. Is that correct?
Looks like it.
I guess so. Maybe there's a lot of late comers. That's strange. But anyway, yeah, you can see the correct answer is indeed phlebolymphodema. There we go, and that's pretty obvious actually. Everybody got stasis pigmentation, we got limb and foot swelling, we got some concavity, distally consistent chronic lipodermatosclerosis. Now, keep in mind, this question is definitely a softball. It is gonna be much harder.
Yeah, it gets more challenging, I think.
Oh, much more challenging. Yeah, this is just a softball, so don't feel too confident. Let's hope we get more responses on the next question. All right, again, one of the similar question. Identify the predominant cause of this leg swelling. Is this consistent with primary lymphedema, chronic venous insufficiency, pretibial myxedema, or lipedema? Go ahead and cue in your answers.
Steve, have you ever heard of Kahoot before today or before this?
One other time. Yeah.
My kids, I guess they use this a lot in school.
Yeah, no, in fact, it was at a medical meeting. Good. Clear majority got the correct answer here is lipedema. Let's see, somebody put primary lymphedema. I would just say primary lymphedema, the majority of primary lymphedema would not be this symmetric. You would have significant foot and toe swelling, which you don't see here. This also, if you'll notice, you see this pear-shaped configuration to this woman's body, very classic for lipedema with a truncal lower extremity mismatch, discordance in this size. Also see the mattressing phenomenon along the thighs, consistent with a stage 2 lipedema, and also a little bit of ankle cuffing here. So this is just clinically classic lipedema, and wouldn't confuse that with primary lymphedema. But, and again, this is another softball. So things are going to get a little more difficult. So let's go on to our third question. Where does manual lymphatic drainage sequencing begin? Does it begin in the abdomen, the location of the edema, the axilla, or the neck or clavicle?
This is a tricky one.
And Julie, what's that, Tony?
No, this is a tricky one. If you
Yeah,
know it or you don't know.
Yeah. Julie Green, the certified lymphedema therapist,
So
in
talk
charge
about,
of this, created this
talk about-
question just would be, this is the softball for the certified lymphedema therapist in attendance, no doubt. But for clinicians, oh yeah, see, you can already see there's a little bit of disparity in the answers here. So the correct answer is neck and clavicle, which the majority got correct, but some other answers out there. So I'm not going to go through why on this because I've got another question that explains this. It's
So
sort
we
of a
got
follow-up.
Beth Knoll is the lead here with 29.33. Second place is only about 100 points away, not even.
So what I hear you saying is competition is fierce. Oh
It
yeah,
is.
look at that.
Look at
Yeah,
that.
Beth and Sarah, yeah. And Jay is not far behind, and then Kathleen
Kathleen.
L.
There are only
Kathleen.
300-400 points between each other.
Yeah, and it could be a difference of a magazine subscription. All right. So next question, which of the following is characteristic of primary lymphedema? Would it be the red triangle, the blue diamond leg, the yellow circle leg, or the green square leg? Go ahead and place your answers.
So Steve, what do you think the valuation of Kahoot is? You want to talk about facts?
I'm sorry, Trina, what about Kahoot?
This app that you have there that we're using, Kahoot.
Yeah.
Has a 1.5 billion valuation.
Okay. I'm impressed.
Yeah. Simple thing, huh?
Okay, now this is very interesting. So I give it up to the 7 of you that got the slide here, or the photograph on the left here. That's and I gave you a little bit of cluing on that previous description of lipedema because I mentioned there was an absence of significant foot and toe swelling. The only image you see here with significant foot and toe swelling is on the left-hand side. This is classic primary lymphedema. Now, for the 10 of you that's interesting that you chose this right here, the green square. You know, first of all, there's no significant foot and toe swelling, so it would make primary lymphedema unlikely. Not that you couldn't have primary lymphedema without foot and toe swelling, it's just very unlikely. And again, this by far jumps out. But as far as what this is, that's actually a plexiform neuroma in a patient with neurofibromatosis. So there's actually no significant lymphedema there. And of course, you have, nobody picked, well, one person picked this, and this was actually a hematoma here with a little bit of venous disease. So anyway, that's interesting. That's the first time actually a minority of respondents got this correct. But anyway, so congratulations, you picked A. All right, our next question. Which of the following subjects is most likely to manifest a positive Stimmer sign? Would be our red triangle, our blue diamond, our yellow circle, or our green square? Go ahead and put in your answers. Positive Stimmer sign. Done. Okay, looks like good. The majority of you got this correct, and that was actually right here, our first slide. And so what's a positive Stimmer sign? It's defined as an inability to pinch or pick up or tint the base of the second toe. And I suspect you'd actually have no chance of pinching the base of that second toe. Whereas the rest of these subjects do not have significant foot or toe swelling. You should be able to easily pinch and tent the toe. Now, Tony, don't you wonder when you see this, what in the heck is going on here with this poor patient's limbs? Just for that, that's actually a.
Is this after a burn?
Yeah, after no, it certainly looks like. Oh gosh, here we go back here.
It almost looks like the patient had a burn and they did skin grafts and ended up with lymphedema.
Yeah, well, this is actually the modified Charles procedure, which is still done in this day. What they do is they go down and strip off all the skin, the underlying fatty tissue, so you're down to the fascia, and then they do end up skin grafting like you stated. So that's and of course, it's a very disfiguring surgery. It doesn't look quite this bad now, but the bane of the surgery is unfortunately worsening acral lymphedema, as seen here.
Yeah.
I've seen a couple of these done in my institution. They actually look much better than this, and so it's still out there though. Modified Charles procedure. So anyway, the majority you got that correct. Again, no way you could pinch the base of that second toe.
Yeah, I mean, if for people that are joining late onto this event, if you look at the chat box on the right there, there is a code that you need in order to enter and join the game. And at the end of this round, there'll be a different code for round 2. So you can either join right now or on round 2. But we encourage you to participate as practice even now, even though we've already started this round.
Yeah, because when you look at this, it says we have 72 attendees, and obviously we don't have 72 respondents. So you want to just give a little bit of time for
people are afraid that you're going to just, like your questions are too difficult.
Sure. That's well, nothing else. They're learning something. But gosh, you could play for a subscription to a couple of highly esteemed medical journals. Gotta log in.
And then sell it on eBay.
Yeah, you could do that. Yeah. So maybe we have. Okay, well, let's see if anybody else logged in here. Let's say we have the Fish that is participating. That's. Well, that could be Dr. John Fish. Who knows?
Is it Dr. Fish?
It says the Fish. All right, here is one of our Julie Green questions. What is a lymphatic watershed? Is this a dual lymphatic flow from the veins and lymphatic vessels? Narrow anatomical zones where the direction of lymphatic flow changes? Areas to avoid during manual lymphatic drainage, or pockets in the body where excess water or fluid is stored? Go ahead and place your answers. A few more people signing up, it looks like here. That's good.
Very good.
Okay, good. Well, I guess maybe it was a little bit too easy because the majority of you got the correct answer, which is narrow anatomical zones where the direction of lymphatic flow changes. Here's our watershed illustration, and you here see the watershed areas typically run down the midline. Here we got sagittal, upper horizontal, lower horizontal, inguinal, or gluteal. So good. I guess that's an easy question. And again, a few more respondents, so that's good to see. What is the most likely cutaneous complication of this disorder? Would it be cellulitis, a stasis dermatitis, easy bruising, or stasis papillomatosis? Go ahead and place your answers. After you place that answer.
Is this really a complication?
Yeah. Well, it's it depends on how you want to define complication. We could say manifestation if that makes you feel better. Okay.
All right.
Does that make you feel better? Manifestation? Okay.
And wow, all over the place.
all over the place, and I congratulate the preponderance of respondents that got this correct, which is easy bruising. That's one of the hallmarks of lipedema. First of all, this is lipedema. Again, you can see that pear-shaped configuration, and easy bruising is again a classic hallmark seen in around 70 to 80% of patients with lipedema, and likely reflects the underlying capillary fragility that these patients have, because it is it's now recognized as a connective tissue disease, so that it certainly can affect the veins, the capillaries.
So this concludes our first round, huh?
Yeah, and it looks, yeah, you're exactly right. You want to say anything about our top three there? They'd be going on to Final Jeopardy, Tony?
Yeah, Sarah, the fish, and Jay.
Okay. Yes.
So 2 people got 6 out of 7 correct, and the fish got 5 out of 7. So
yeah, pretty strong there.
yeah. So which game show is this? Steve?
It sure looks like, is that Wheel of Fortune maybe?
Yeah. So you know that there was only really, throughout the years of Wheel of Fortune, there has only been one wheel.
No, that's some
One
interesting
wheel
there.
and one wheel and one puzzle board. They've used the same ones throughout the years.
Huh. Very
And then Vanna never wore the same dress more than once.
I would, somewhere in the back of my mind, I think I remember hearing that before. That does sound.
All right, Larry, let's see your $1,000 question. How many times does the letter E appear in the following phrase? Pledge.
So for those who are going to be participating in round 2, hopefully more than the previous round, there is the game pin in your chat box. So please use that pin.
You get their paper. If you like their answer, you can go with it. If you don't like it, you can go with your own.
So what's this one, Steve?
Oh, that sure looks like are you smarter than a 5th grader?
Yeah, we're going to hold off, Steve, a little bit, give more time for everybody to put in the code.
Okay, yeah, because even if you didn't participate in that first round, you can still get to Final Jeopardy.
Yeah, all you have to win is be one of the top 3 in the round 2 or 3.
Yeah.
So what other shows has the creator of Smarter Than a 5th Grader? Do you know? Well, first of all, it's Mark Burnett. That's the creator. Survivor and The Apprentice.
Huh.
So you go from apprentice to Are You Smarter Than a 5th grader?
Yeah, that's wild.
Well, so far it's been, okay. What do you think, Steve? How are we doing?
I think we're doing fine. Yeah, we're doing well on time. It's just a matter of hope we have some more people ready to participate in the showdown.
Yeah. So again, guys, in the chat function, let's see here. Round 2 game pin is 791-5087.
And now we got 22 signed up, Tony.
Okay.
Of those 72 that are out there, come on, people.
Come on, guys.
75 now are out there watching this. So, yeah, you join the fun.
If you have, you can go to your app store and just look up Kahoot, or go to the website kahoot.com, and you can download, play. What's the longest running TV game show?
Oh, what is the Price is Right?
You got it.
Thank you.
So
I didn't discuss that. We did not talk about that beforehand.
all right. Well, more people are still signing in, so you want to give a couple more minutes. So what game, Steve, do you get to call a friend? Was that a friend calling?
I'm not sure who it was, actually.
Which show you're able to call a friend for help?
Oh, yeah. Oh, gosh, what was that?
I don't remember. I just came.
$1,000? What was that?
If anybody
Can I have a
knows,
choice on that? Just give me 4 choices, Tony, and I'll get it correctly.
you think I don't know. I just thought of it because your phone was ringing. It's the.
But Tony, it still looks like you let me know when you want to go.
All right, let's go.
All right,
Let's go
round
to
2.
Round 2.
Let's do it. A 28-year-old presents with leg swelling that spontaneously began in her late teens. Name this disorder. Is this consistent with Klippel-Trenaunay syndrome, yellow nail syndrome, lymphedema tarda, or lymphedema precox? Go ahead and place your answers.
Ten seconds.
Yeah.
Yellow nail syndrome. I don't think I know that one.
Oh, it's out there, John. They have yellow nails. So I congratulate the majority of you that, or at least a plurality, it looks like. They've got this correct, which was lymphedema precox. Let's see, what can we talk about lymphedema precox? Well, it is the most common type of primary lymphedema, typically in females, anywhere from 10 to 20 times more likely to affect a female than a male. Usually presents in adolescence, early 20s, and it looks like this. You can see the dorsal pedal swelling. It's usually more severe in one limb than the other. In fact, a lot of times it is unilateral, and as time goes on, you'll start to see it evolve in the contralateral limb. As far as Klippel-Trenaunay, there's no cutaneous manifestations of Klippel-Trenaunay syndrome, and there certainly are not yellow nails. And lymphedema tarda presents after the age of 35 or 40. All right. Well, so we had a tie on that. So that means they put in the, yeah, there's 2
Exact
ties.
same time.
Wow. What are the chances?
Yeah.
Mitch and Beth Knoll. Okay. All right, next question. What is the most likely cause? I know you're probably wondering anatomically, what are we looking at here? Just to get you oriented, that's actually a chest wall. So what is the most likely cause of this unusual pattern on a chest wall? Is this consistent with lymphoma, histoplasmosis, a pacemaker, or radiation? Go ahead and place your answers.
You just have to be very observant here, right?
Yes, yes, exactly. And the patient typically would have left arm swelling as well. Some phlebolymphodema.
I thought you're not giving any clues, Steve.
Well, but I don't think that's really going to help them in as far as identifying the cause. So, okay, here we go. The correct answer, again, I congratulate Jordy, you got this correct. It is a pacemaker. So, first of all, what we're seeing here is this marked venous collateralization across the chest wall, which typically is occurring in the setting of an innominate subclavian vein occlusion. So then it becomes about what's most likely to cause that. All these things can cause it, but the big clue, like Tony just referenced here, is what are you seeing here? There's a pacemaker pocket. So that's, hopefully you saw that. Hard to miss that on examination, unless you don't look. Tony, anything else you want to say about this? I always find this an interesting condition because a lot of times people just overlook this because they get a venous duplex ultrasound and it's negative within the axillary brachial and distal mid subclavian veins and not realizing it's occurring in the innominate vein or proximal subclavian vein. It just doesn't show up on the ultrasound.
I said it was pretty impressive collaterals in the chest wall.
Yeah, absolutely. All from a pacemaker. All right, another certified lymphedema therapist question from Julie. Why does manual lymphatic drainage begin at the clavicle? It's because it stimulates innominate venous flow. Is it the terminal lymphatic drainage pathway? Is it because it stimulates subclavian venous flow, or is it the initial lymphatic drainage pathway? Place your answers.
There we go.
Good. Yeah, very strong, very strong. Yes, the correct answer would be terminal lymphatic drainage pathway under both the right and the left clavicles. As far as the right clavicle, underneath that, we have our right lymphatic duct emptying into the right jugulosubclavian junction, as seen here, draining the right hemifacial region, right hemithorax and right upper extremity. And on the left side, under the left clavicle, of course, we have the thoracic duct emptying into the left jugulosubclavian junction and draining the anatomic areas as seen here. So that's why MLD begins at the clavicle. So how are we doing, Tony, as far as scores here?
Let's see, what we got? Rob's leading the pack.
Yeah.
Sarah, number 2, and LED. So some of you are using code names. I would, from the previous round and also from this round, which is okay. Just chat and let us know who these code names are, because if you've won and you're part of the top 3, we need to send you the login code for the final round. And if we don't know who you are, we can't send it to you.
All right, ready for the next question? What is the most likely cause of leg swelling in a patient that presents with the following foot and toes? And they have swelling, by the way, in their feet that goes all the way up into the upper calves. Is this consistent with primary lymphedema, secondary lymphedema from a lymph node dissection, secondary lymphedema from radiation, or secondary lymphedema from chronic venous insufficiency or phlebolymphodema?
Very classic findings here.
Oh, yes, it's textbook, if you will, Tony, textbook. Okay, again, this is a learned audience. The clear majority got the correct answer, which is primary lymphedema. So why is this consistent with primary lymphedema? Well, anytime you see these bizarre dysmorphic appearing toes and toenails, that's consistent with primary lymphedema. You should not be seeing this in secondary lymphedema. I mean, look at these incredible, deep, transversely oriented digital skin creases. That deep, be very unusual in a secondary lymphedema case. Also, look at the toenails, incredibly hypoplastic. And not just hypoplastic, they're actually upturned as well. Again, not something you're typically going to see in secondary lymphedema. Sometimes these are referred to as ski jump toenails, but like Tony said, just a textbook classic representation of primary lymphedema. And to go back as far as secondary lymphedema, I don't know how you would distinguish between radiation or lymph node dissection. You clearly don't have any evidence of stasis pigmentation, which some of you chose here. Not that you necessarily see it on the foot and toes, but you shouldn't see toes that look like that in phlebolymphodema. All right, next question. Identify the correct response. The left leg manifest ISL, or International Society of Lymphology Stage 2 lymphedema. Lymphedema is excluded by the absence of significant marked dorsal foot swelling. This disorder is more common in males or greater than 50% of the left limb volume is due to fat? Put in your answers. Oh, what do you think about that, Tony? You see here the correct answer, which again, the majority have got this correct, is greater than 50% of the left limb volume is due to fat. That would be the correct answer. Now, it's interesting that the incorrect answers that were queued in were distributed equally among the following, or the initial 3 distractors. So let's go through that. Left leg limb manifest ISL stage 2, that's clearly ISL stage 3 or elephantiasis lymphedema. I mean, when you have that much swelling, actually fat deposition, markedly exaggerated skin creases, and you can see the lymphostatic papillomatosis along there. So that's a stage 3. Lymphedema is excluded by the absence of marked foot swelling. That is not true. You can have lymphedema without marked foot swelling. Very important point that you need to be aware of. And like most lymphedema cases, most lymphedema is more common in females by far than males. This is a primary lymphedema case. That's the only exception, at least in, for instance, our Ohio State data was in the phlebo-lymphedema group where it's equally distributed. But lymphedema is a disease of females as a whole. And so the key point here is greater than 50% of left limb volume is due to fat. Lymphatic fluid, lymphedema, stimulates local fat deposition, which is typically diet resistant. And that's why, well, actually I've got another question. We'll talk about that. But there's probably 75, 80% fat in that left limb. All right. Another question by Julie. Lymphatic vessels are subdivided into capillaries, precollectors, collectors, and trunks. Capillaries, perforating collectors and trunks. Ducts, perforating collectors, and mitigating vessels, or ducts, horizontal, vertical collectors, and mitigating vessels. What is the correct answer? So a little lymphatic anatomy 101.
I have a feeling we're going to have some diverse answers here.
I agree with you.
Whoa.
Tony, good thing we didn't bet on this.
Bet on that one, yeah.
Yeah, exactly. So the clear majority got the correct answers: capillaries, precollectors, collectors, and trunks. And I'm really going to discuss that just because, in the interest of time, and obviously the majority of you know the correct answer. And I don't know what a mitigating vessel is. Tony, have you ever heard that term before? I have no idea.
So Kathleen's leading. LED number 2.
Kathleen, LED. Yeah.
And Estrelita Diva.
Okay. Well, good. All right. So on to our next question. I think we're almost at the end of round 2. Identify the most effective therapy for this disorder. Would it be a gastric bypass, pneumatic compression device, liposuction, or manual lymphatic drainage? What would be the most effective therapy? I mean, these are all potential therapies, of course, but what's most effective?
Do you think they're all effective?
The most effective, though. Oh, good. So again, Jordy got this correct. Correct answer would be liposuction, although, you know, Tactile's got to be happy that a pneumatic compression device was the second most common answer here. But anyway, by far, most effective therapy is liposuction. I mean, you can compress, you can elevate, whatever you want to do, and it's not going to make that big of a difference because this is diet-resistant fat. Now, of interest, gastric bypass, which fortunately none of you chose. You can see this patient's actually already undergone the gastric bypass, and her legs did not appreciably change.
All right.
All right. So, Tony, we're going to stop here. We'll have this in the background while you look at the, we'll find out who is moving on to Final Jeopardy.
Steve, why don't you pause that for a second? So we have Kathleen in first place, 5861. Estrelita Diva in second place, and David in third. Very close score.
David came out of nowhere. I didn't see
Yeah.
David on there.
No.
I'm impressed. I'm really impressed.
So again, for those 70 plus people, we want to see some of you play the final round here if you want to win one of the journal subscriptions. And in the chat box, you'll see the code, the game pin code. So please, if you have the app downloaded, participate and have fun.
Yeah, win a subscription.
So which
Right, Tony.
which game is this one?
And you get this up your child. If you're divorced and one person has it, they get and civil. Shepherd. No, civil. And this is some Dear Abby is a
Dear Abby.
Tony, what was the answer? Because that's not Family Feud.
No, that's Pyramid.
What is it?
Pyramid.
Oh, Pyramid. Gosh, yeah. How can I forget?
Yeah. You know, actually Billy Crystal holds the record in getting to the top of the pyramid fastest.
Yeah, I can remember Tony Crystal. Yeah, or Tony, Billy.
It's actually, it's second only to the Jeopardy in number of Emmys, 9 Emmys for that game.
fingers.
7 fingers.
For hygiene purposes, name a product you hope everyone uses.
I guess that one wasn't working.
Well, it looks like we probably better move on in the interest of time here.
Yeah.
So round 3. Identify the most likely etiology. And as far as etiology of what exactly, it's this protuberance. Is this consistent with Raucheria bancroftii, or not consistent, but is the cause Raucheria bancroftii, that parasite, inferior vena cava occlusion, sarcoma, or morbid obesity?
It's not an IVC occlusion, that's for sure.
Tony, you don't want to tell them that they're putting answers
You
in.
gave him a clue before. I can give him one now.
Okay, all right. Tony, one person inferior vena cava occlusion, so maybe listen.
Yeah, they can't change the answer in this game, unfortunately. So if they had picked it already.
Okay. Yeah, same thing here. So the correct answer is actually morbid obesity. And note that I have in italics here, it's most likely etiology. This is actually a classic example, textbook, if you will, of massive localized lymphedema, also known as pseudotumors or pseudosarcomas. And clearly this is a quickly rising complication of the obesity epidemic. And not that those other entities couldn't potentially cause it, it's just definitely not the most likely cause. In fact, this can degenerate into a sarcoma, but you don't see any skin findings or anything that's suggestive of a sarcoma, and it wouldn't be the most likely. All right, what's the most common cause of primary lymphedema? Is it lymphedema precox, chronic venous insufficiency, cancer with lymph node dissection, or radiation?
Well, I know what's the most common cause of secondary lymphedema, thanks to your paper.
Tony, you're giving some cluing there.
Well, I said secondary. I didn't say primary.
Okay, and well, Tony, so 2 people did choose chronic venous insufficiency or phlebolymphodema, which of course is a secondary cause of lymphedema, not primary. And clearly this was a little bit easy here as the majority got this correct. It's primary or lymphedema precox, the most common type of primary lymphedema. Okay. Oh, another Julie Green question. Short stretch bandages display high resting pressure, high working pressure, low resting pressure, low working pressure, high resting pressure, low working pressure, or low resting pressure, high working pressure. Confusing.
Yes.
That was a mouthful to say.
Do, 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 do. What show?
1 second. That's Jeopardy. Come on, Rick.
Softball for you.
Oh, so that was, look how easy that was. Clear majority got that correct. Short stretch, relatively inelastic bandages, low resting pressure, but high working pressure. Then that calf muscle pump. All right, identify the abdominal pathology. Is this abdominal panniculus moribundus, abdominal sarcoma, abdominal lipedema, or abdominal lymphatic wicking? Tony, this was a patient of mine that I referred to. You should be getting the consultation information in the mail soon.
I saw her yesterday. Well, I did it through, telemedicine.
Okay, well, that's probably smart.
Yeah, because, she didn't want to travel here.
So this was, majority got this correct again, abdominal panniculus moribundus. Yeah, unfortunately, I probably see 1 or 2 of these a month. Yeah, self-explanatory, but that is one of the most dramatic cases I've ever seen. Not really sure what abdominal lymphatic wicking is. I thought maybe people would, even see one person chose it. I just made it up, and I did get somebody to pick it. So it worked. All right, next question. Why does the right leg not pit with pressure? Is it because of excessive fibrosis, excessive fat, excessive fibrosis and fat, or none of the above?
Zero.
Aha, good. Again, the majority got this correct. It's interesting to see who punched in the answer the quickest. Yeah, it's excessive fibrosis and fat. We just referenced that. Over half of that limb volume is due to fat. Fat does not compress.
We got Perk, Sarah, and Estrelita again in the top 3.
Yeah, but then again, Sarah and Estrelita wouldn't be. I mean, they can play, which is good, but they're not going to count because they're already in anyway. So yeah, just like Kathleen L is already in, and me, it's like me's in there. Which of the following skin changes can be mistaken for a healed venous limb ulcer? Stasis dermatitis, is this atrophy blanche, acroangiodermatitis, or lipodermatosclerosis?
Hey, Steve, I'm really enjoying this.
Oh, I am too. How could you not enjoy it? It's
I think we should take this show on the road.
I'm ready. I'm ready. We just need some financial support, and we could do it. All right. Oh gosh, again, just too easy here. Atrophy blanche being the correct answer, and that's once again to borrow Tony's verbiage. This would be a textbook classic representation of atrophy blanche. All right, and here is our last one in round 3. What is the most likely explanation for the painless left leg discoloration? Is this lymphedema rubra, cellulitis, an acute iliofemoral DVT, or reflex sympathetic dystrophy? which I have seen rarely complicate lymphedema. Rarely, rarely, rarely. Secondary lymphedema.
3, 2, 1.
Curious up. Oh, good. Yeah, again, this is a pretty sharp audience.
Yeah.
Lymphedema rubra, also known as lymphatic rubor, would be the correct answer. And it's painless. These other three conditions should be markedly painful. So that right there should exclude those as possibilities. Anyway, just reflective of the chronic inflammatory state of lymphedema within the dermis. So, all right, let's add things up here and see who's going on to Final Jeopardy. I'll let you say what you need to say here, Tony.
All right. Well, for the winners, there's actually, I'm going to announce who they are. Marlon Schultz, Sarah Salinas, Jackie Ruske, Kathleen Listen, David Haraway, and Estrelita Diva. The code for the final round will be texted to you in the chat box. So please enter it to take part of the final elimination round. We also have Perk, G, and Krista.
Yeah, keep in mind here, this is single elimination. You cannot get back up like this guy is here. When you're down, you're down, you're out. Well, Tony, we're gonna have to just skip on here in the interest of time. So tell me when we're ready to go.
Well, a little fact on the previous, go back one slide. You have 8 minutes. So this is the dating game. So this was in the 60s.
All right, bachelor number 1. There's
You
something
don't
wrong
have
with
to,
it.
you don't have to play, but an interesting fact I found out is that the winners would go to these, they would send them out on these romantic trips, Paris, Italy, but they would be sent out with chaperones because parents wouldn't let a stranger take their daughter to Paris.
That is interesting.
Yeah, different
Which
world.
one?
We live
I don't
back
see that
in
happening
the
anymore.
60s and 70s. All right, you want to go on to the single elimination? Is everybody ready?
It looks like we have 8. We should have one more. There's 8 registers. There should be 9. There we go. Okay, we are ready. Let's
All
go.
right, let's go.
Let's do it.
Pay attention, guys. No.
All right. Question number 1. Choose the correct International Society of Lymphedema classification for the following limb. Is this a stage 2, a stage 3, a stage 4, or stage 5?
All right. 3, 2. Enter your answer now.
Oh, so see already we weeded some people out. I congratulate majority that got this correct. This is actually ISL stage 3. Some of you chose stage 4. There is no stage 4 in the International Society of Lymphology staging criteria. Maybe Campisi criteria you'd see it, but not in a ISL. ISL stage 3 is the highest you can get. So we're down to 6. 6,
Right.
Tony, and then there were 6. All right. Next question. Identify the lymphedema-associated skin disorder. Beer spots, atrophy blanche, pityriasis alba, or vitiligo.
Ooh. Not an easy one. Using up all the time here.
Mm-hmm.
Wow.
Oh, wow. So what are we going to, Tony? I guess we're
done.
because we only
Only one person got it right.
Yeah, one Perk. Perk would be the winner. You can see here these white. These are referred to as physiologic anemic macules, also known as beer spots. Which Tony, here's a little historical fact: were identified by Augustus Beer, the surgeon that created the beer block. So not only did he identify the beer block for local anesthesia, he identified these white spots that often complicate the veno-lymphatic hypertension, which is pretty remarkable when you think about it.
So our top three winners is Perk, Krista, and Kathleen Listen.
Yeah. Okay.
They each get a subscription.
Yeah. That's impressive. Perk kind of came out of nowhere because I don't remember seeing Perk in the first 2 rounds, so they came on strong in that 3rd round. That's impressive.
And I think I also heard a rumor that the next live AVLS meeting, they also get a drink at the bar.
Oh, well, that's impressive. Yeah, that's
Well,
very, very impressive.
Did you say you were? I thought you were offering that, no?
No, not that I know of. Nobody's contacted me about that.
Oh.
Well,
Right.
so we have plenty of questions still to use in the future if need be, because there were, I think, about 7 or 8 more Final Jeopardy questions. So that's good to know. Got some in the bank, as they say.
Are there any questions in the chat room?
Yeah, let's see here. You want me to stop sharing my screen? Let me stop sharing here. How can I? Here we go.
So for the 3 winners, Tactile will be contacting you through the registration list in order to pick your prizes.
Boy, that worked out well from a timing standpoint.
Yeah, no.
Dicey there.
You only got 3 minutes, so I think we should just end this, as I know there's another Tactile event after this. I want to thank Tactile for putting this together, and of course, Steve, your incredible work in putting these slides together, and awesome session. And I hope you guys, this is the beginning of a great AVLS meeting, and enjoy the entire meeting.
Yeah, Tony, look at this. There were 85 people here that watched this, 85, and only 22 or 21 of you participated. But that's okay. At least I'm glad they watched it.
Yeah, we'll learn some things.
Yeah.
So thank you everybody for participating and taking part of this, and enjoy your evening, and see you hopefully one day live.
Yeah.
Bye-bye now.
Yeah, good evening, everybody.
Okay, well now we'd like to begin the collaborative approach to treating phlebo lymphedema portion of tonight's program, sponsored by Tactile Medical. As a reminder, all attendees are muted so we don't pick up any background noise during the program. You can type any questions into your control panel screen and it will be added to a queue. The Q&A portion of the webinar will take place at the end of the session. I will now turn over the presentation to Lear Section Chair Robin Bjork and Co-Chair Heather Hetrick.
Hi, everyone. Thank you so much for coming. Hi, Heather. Good to see you tonight. Thank you so much for participating, and thank you to Tactile Medical for sponsoring both the trivia and this next presentation. And Steve and Tony, that was fabulous. Very fun, very fun. So we're going to just go over a little bit about Lear. It's just very brief to tell you a little bit about this section, and then Julie will introduce the speakers for tonight's topic, a collaborative approach to treating phlebolymphedema. And Brian, if you would advance the slides, that would be great. Thank you. So what does Lear stand for? It stands for Lymphatic and Integumentary Rehabilitation. It's the newest special interest section of the AVLS, and it is now the official name for what was called before the lymphedema section. And Heather's going to speak to this, but it embraces a broader scope of clinical practice and influence. Next slide. So I'm the chair, and Heather also here is co-chair, and I just want to say a special thank you to Julie and Christina, who are also part of the Lear Steering Committee, because they were instrumental in organizing this entire evening. So thank you so much, Julie and Christina. Next slide. Go ahead, Heather. Could you back up one, Brian, please? Oh, okay, go forward. I guess you went. This section is for all members of the AVLS who have an interest in chronic edema, lymphedema, lipedema management, and associated skin and wound management and comprehensive rehabilitation. Heather's going to speak to that on the next slide as she goes over the new definition for this section as well.
It keeps skipping. There we go. Great, thank you. So this is the description we came up to try to make a comprehensive overview of what Lear or lymphatic integumentary rehab is designed basically to be comprehensively and holistically address patient management issues, associated complications, and contributing factors that lead to lymphatic, integumentary, and functional impairments related to lymphedema. And I'm sure all of you can appreciate that. Lymphatic pathophysiology really requires a team approach to maximize patient outcomes and requires knowledge and appreciation of the interrelationship of the body systems for prehabilitation, rehabilitation, restoration, and maintenance to improve quality of life. So next slide, please. Thank you.
So we want everyone who has an interest in these areas to become a part of the Lear section. The exciting part of this is it's brand new, so we can make it whatever we want it to be. So for non-members, AVLS non-members, the first step is to become a member of AVLS. And so you can simply go to the AVLS website and click Join AVLS and download the application. Next slide. On the application, I highlighted in yellow here, you can join the specialty section, lymphatic and integumentary rehabilitation. And just note, there's no additional charge to join the section. Next slide. If you're already an AVLS member, we're trying to use the MAC community as our point of communication and contact with each other. So please click on the AVLS tab, go to the MAC community, and the next slide, please. And then when you're in the communities, you can search communities for special interest groups, and you'll see that the different sections come up, the ultrasonography section and then lymphatic and integumentary rehabilitation specialty section are pictured here. Right next to that, to the right of it, there should be a button, join, and you just simply click join, and that will add you to this special community. Next section. So we have one special project that we've identified so far that I think would be great to work on together, and that is lymphedema treatment protocol for phlebolymphodema. But right now we're just trying to launch this new section, get everybody connected through the MAC community. And after this AVLS Congress, we'll start to send out communications and invite different people to be involved in special projects and also give your input on what kind of projects you'd like the group to work on. And next slide. And we just want to thank you again, and thank Tactile again for this, Julie and Christina, and also for anyone that misses this session, it will be recorded and posted afterwards. Thanks so much, and I hope you enjoy this.
Thanks, Robin. And Julie, can I just say one thing really quick? I just want to make sure people appreciate that this is not just for PTs and OTs. This is all comprehensive. I know we use the word rehabilitation, but it's meant just to be that collective holistic term to help patients navigate the disease of lymphedema, phlebolymphodema, and the associated integumentary impairments. So this is meant to be an all-inclusive special interest group. So everybody's welcome, and we look forward to working with you.
Okay, thank you, Heather, and thank you, Robin. So my name is Julie Green. I am excited to be part of this group, as well as and I'm working at Tactile Medical, and I just want to talk a little bit about the objectives for this evening's session. So we are really excited to have some great speakers tonight and to discuss really good ways that vein specialists, vascular doctors, and lymphedema specialists and PAs and RNs can really collaborate and work together. So there are going to be discussed pathways vein specialists and therapists can utilize and provide comprehensive care to patients with phlebolymphedema, implement lymphedema into your vein practice to improve patient outcomes, and overcome any potential barriers and challenges when incorporating lymphedema treatment into your vein practice. So a lot of good topics are going to be talked about, and we're going to have a number of speakers really talk about how they have collaborated, why they got together, what really initiated having a vein specialist bring in a lymphedema specialist or partner with the lymphedema specialist, and how that really turned their practice around. Okay, next slide. So the first group is Dr. Fernandez, and he is a vein specialist at the Center for Vein Restoration in Maryland, and he has his therapist, Gita, who's a certified lymphedema therapist, and they work for Center for Vein Restoration together, and they work together, and I'm gonna let them really describe what it's like for their practice and how it has changed their practice. And then the second group of presenters is going to be, if you can go on to the next slide, thank you. Dr. Hamilton and Shauna Gordon, who's a PA, and Christina Hankins, who's also a lymphedema therapist, and how they have really incorporated lymphedema treatment into their practice, and talking about some of the challenges and barriers that they've come across, as well as some of the outcomes, and really talking about several case studies as well. So I'm going to turn it over to Dr. Fernandez and have him really talk about his team. Okay, you're muted.
Thank you. Can you see my screen?
I can, yes.
Wonderful. And I have control over the slides, correct?
Actually, they're going to be advanced for you. You can just go ahead and tell him next when you want to move to the next slide.
Okay, great. So if you don't mind advancing, I just want to say thank you so much. Thank you to Tactile for sponsoring this session. As you already are aware, we're going to be chatting about collaborative management of lymphedema and phlebolymphedema in this case, which is really an orphan disease together with lymphedema. So please advance. We have no disclosures. Gita and myself, we just are part of Center for Vein Restoration in collaborative approach with Center for Vascular Medicine. Next slide. So phlebolymphedema. Lymphedema, as we know, we talked about being most common worldwide, secondary to filariasis infection. In the Western world, really is most common not to cancer diagnosis, but it's really secondary to chronic venous insufficiency. Chronic venous insufficiency is the most common vascular disorder worldwide. So if we're really going to look at it, we could really extrapolate, they're just not good studies, that phlebolymphedema is probably a worldwide phenomenon that is really ignored. It's a mixed etiology of swelling due to chronic venous insufficiency and lymphatic insufficiency. And you can look at it as the inability of the lymphatic system to adequately drain the interstitial fluid resulting from chronic venous insufficiency, or the damage that that lymphatic system has sustained from chronic venous insufficiency. Next slide. So here's, I know we just finished some trivia, but very briefly, what is the ICD-10 code for phlebolymphedema? Next slide. And keep going, please. All the way. Yes. Back, please. So yeah, we have ICD-10 codes for sucked into engines, contact with cows, and even spacecraft collision, but yet we have no ICD-10 code to specify the diagnosis of phlebolymphedema. So next slide. So really, this is all you get. You get an I-89 and a Q-82 code for our entire world of lymphedema, but in this case, there's subsequent markers and definitions that we're starting to really pinpoint that that we still cannot present to the medical community, even to insurers, to get a proper credit as to how we identified and manage this condition. Next slide, please. And this is where we've gone wrong. We have looked and we have educated our providers in a very separate approach. We've looked at the pelvis, vascular structures. We've in the past looked at venous and arterial in the peripheral limbs, and we looked at lymphatics, and we sort of have separated these three worlds. And what we should be doing, next slide, please, is to really bring this together as one. All of the systems work in conjunction with each other. There's a very nice balance, and it's when this balance is dislodged that we get a problem, whether it's from the arterial, the venous, or the lymphatic side. They're all interconnected, and we have to see our specialties as interconnected for the greater good of our patients. Next slide. So it's a multidisciplinary approach. Even Hollywood has gotten it right. It doesn't take one hero, but a multiple heroes to get the job done. So this is really where the patients benefit the most. We benefit the most as providers in providing great care. They have access to an entire team of phlebologists, deep venous vascular specialists, lymphedema therapists. This all improves diagnosis to treatment and outcomes. You have better patient education, which is equal to better compliance. Patients with wounds have faster healing times. And obviously from a benefit to your practice, you have increased referrer satisfaction as well as patient satisfaction, and those are very much cross-linked. Next slide, please. So what is our approach? Our approach is really straightforward. It's venous evaluation from a clinical and ultrasound at the same time initially. And we come from a vein practice, primary vein practice. We had the great benefit of the vision of our founder. See the need to incorporate lymphedema into the care of these patients almost 8 years ago. So we've been actually working with a collaborative lymphedema therapist that long, and we have been able to really slowly reap the benefits of seeing better patient care, better patient outcomes secondary to this. So these patients, after the initial venous evaluation, will be determined whether they need a pelvic venous congestion, pelvic venous compression evaluation, a lymphedema consultation, or a combination of these. And the follow-up at the end of any of these treatments is critical to keep this patient connected with your practice, whether it is from the simple peripheral venous disease, the pelvic venous disease, or the lymphedema component alone, to make sure that they are compliant and that you are capturing this. Next slide, please. And this is how we can best show you that how we put it together. We have a 58-year-old female with bilateral leg swelling for the past 5 years associated with fatigue, achiness, worsened over the past few years. Really no DVT history, no surgical history, no premises. BMI was 40, a CEAP of 3, and a VCS of 9 initially. Her leg circumference is on the left, 61 centimeters, and 60 centimeters on the right. Next slide, please. So initially placing diuretics with mild relief. This is classic. We see this all the time. Then seen outside vein practice from us, and she underwent several treatments, mainly GSVs and SSVs. She had some transient improvement, but then again, recurrence. Very much similar to those diuretics. You see an initial improvement, and they stay chronically swollen. Same thing here. So she was referred to us for discontinuation of edema. We found initially minimal peripheral disease and suspected that she had a venous outflow obstruction. So she was referred to our Center for Vascular Medicine, which is our collaborative deep and arterial specialist for evaluation. Please, next slide. And this is in a very shortened view how it came across. They found under initial screening, and they used actually ultrasound for screening, and based on her history, that she had a high suspicion of iliac compression. they proceeded to do a venogram, and here you see a classic bilateral iliac compression in narrowing. So you see that dye flow that kind of becomes very faint about halfway to your screen. And next slide, please. And post-intervention, you see stenting. You can sort of see a little bit of the mesh of this stenting, and then you can see the difference in flow from something that went very faint to a very much improved flow. So when this patient comes back, next slide, please. At 6 months, her CP is still 3. She's still swollen. Her BCS is now, she feels less fatigue, less heaviness. A lot of her physical symptoms have improved, but she's still swollen. Her leg circumference has not changed much. And so it was felt that she would benefit from some of our lymphedema therapy. So she is sent for that. Next slide, please. And reevaluated, and you start seeing how there is a significant improvement. Then leg circumference continues to improve now, making a much more significant difference in circumference and in both legs. Obviously, the patient is benefiting from that in a multi-factorial approach. Next slide, please. So in all of this, what we're seeing is over our past almost coming to a decade of working with these patients, it's a little bit an uphill struggle to find certain aspects of misinformation, which you are probably experiencing at times. There is the misinformation, as in this case, the venous treatment will resolve edema. We unfortunately do see that, and that is evolving, and that's changing, and people are having better understanding of that. That all edema is venous or lymphedema in nature. And lymphedema is a multifactorial approach. You have to take into consideration not just the venous component, not just the lymphatics, but medications, activity, and other conditions that can be very specific to your patient. Compression stockings alone are sufficient for management of edema. Obviously not true. We need this collaborative approach. Lymphatic pumps, fantastic. I think they're a critical part of the care that we provide our patients, but them alone too do not just do the job. And all lymphatic pumps are the same. We know that. We talked upon diuretics already, and very well known how frustrating this can be, especially getting these patients off of them and trying to talk to their primary care physicians about why they should come off of them. Next slide, please. So where are our challenges? From my perspective as a physician, has been lymphedema therapy involvement. We are blessed with the lymphedema therapists that we've had and that we have right now with Gita. But it becomes a challenge for a lot of lymphedema therapists to really understand this connection at times and how they can be managed together, but also differently. Some of these patients don't require the classic lymphedema management. They can be in a more expedited pathway, which benefits the patient, and obviously in terms of their return to their normal activity, but also from the healthcare dollar perspective, where they saving some money in their overall management of these patients. And obviously complications that arise from incomplete treatments. But therapists also are very attracted to still the management of cancer related lymphedema, which is a big component obviously in our society, unfortunately, and understandably why. But we have trouble because our focus is solely pleural lymphedema and is lymphedema secondary to pelvic venous disease and some lower extremity, but it's really all lower extremity lymphedema, pleural lymphedema. So some therapists miss that connection to their cancer patients. But Gita sees great cases. We see a lot of, unfortunately, male patients from radical prostatectomies that do develop this lymphedema and is not communicated to them. So we do a great job at educating breast cancer patients, but really those with pelvic malignancies and interventions don't really get the same education that we do so well. So she's able to take care of that. So the community physician education and understanding, as well as the patient education and understanding, these are interrelated. Obviously, one affects the other. And physicians, number one, need to have a better understanding of identifying early on the classic signs of lymphedema, phlebolymphedema, getting these patients referred for appropriate evaluation to make sure that we start in the right pathway to diagnosis and management. Again, trying to avoid that slippery slope of the diuretics in which the patients just unfortunately do not improve, and it just leads to further progression of the disease from something that could have been managed at early phase 1 versus a phase 2 and phase 3. And finally, obviously, something that we're all familiar to, one of the greatest challenges is insurance. I mentioned earlier, this is an overall an orphan diagnosis of lymphedema, and even more of phlebolymphedema. And it's just like everybody else is fighting the inability to get a lot of the therapeutics appropriately covered. One of the, as we fight the same battles you might be fighting in getting the proper garments to these patients, in which it's at an extra cost to them, which is not always feasible, especially now during these times of such financial stress to many of our patients. I'm going to open it now to Gita so she can pitch in on her side.
Thank you, Dr. Fernandez. Thanks, Julie, and thanks, Tactile, for giving me this platform to share my experience. Of course, working from my perspective as a CLT, working with vein specialist, it has been extremely helpful in getting a better patient outcome. I get a faster decongestion. Patients are happy to see that outcome. And the best part is I get to see a patient sometimes before the procedure. So patient education has improved a lot, which helps the patient understand like why the lymphatic or why the venous procedures are important, as well as lymphatic therapy, and why the follow-ups that we schedule for the patients, why they are important, why venous and lymphatic health go hand in hand. It's very hard for patients sometimes to understand, like, okay, hey, I'm going to do my procedures, I should be okay. But we have been trying to educate them that both these systems really go hand in hand and they both are equally important. I also like being with CVR, like being with vein specialist at the same level has helped me reach out to them with concerns regarding patients with respect to venous health after procedures. And we have, of course, seen like a huge patient satisfaction rate. Like the patients are really happy. In fact, a lot of my CVR, I've been able to give provide lymphedema education not only to patients but also to my techs, also to my non-clinical staff to help patients. Sometimes patients are in the lobby and they have questions like, what is this? And they are still able to answer a few questions. So I've been fortunate that I've been able to share that knowledge with them. Next slide, please. Challenges, of course, like all fellow therapists out there, and like Dr. Fernandez explained, insurance guidelines, I do face them. I do come across issues in getting patients their garments sometimes on time when they are required like a pre-authorization, which of course all my therapist friends will agree how it delays their therapies. Of course, sometimes I have a hard time scheduling the therapy sessions with the patients when they have a simultaneous procedure going on. And then, of course, trying to, like Dr. Fernandez discussed earlier, educating the community physicians, that sometimes gets really tricky, and reaching out to them regarding the diuretics. why compression stockings are not just the only option. There is it's like a wholesome system, integrated system that is needed to help patients with lymphedema, phlebolymphedema. So next slide, please. Well, I think I'm really fortunate that I'm able to share this knowledge today. I'm really happy. Like, I have learned a lot on the venous side as well with all my physicians at CVR. And of course, I keep updating myself with the lymphatic knowledge through the lymphatic community online. And of course, like Kathleen Leeson, she's up there. I reach out to her time to time on the community. Thanks again, Tactile, and thanks, Dr. Fernandez, again. Thank you so much.
Yeah, thank you. That was great. And I just wanted to ask one or two questions. Actually, if Geeta could come back for a second. Yeah, sorry. Just before I forget and before we move on. So I'm just so impressed that you have been doing this for 8 years. That surprises me, just because I've been out talking to providers and therapists for probably, well, a number of years now. And, you know, one of our goals here at Tactile is to really establish some of these partnerships and some of these relationships and facilitate and help that, as well as us being a partner with you. So what was that first kind of initiative for you, Dr. Fernandez, to think, I want a therapist in-house? So my understanding is she works for your clinic and she travels, right, to each of the clinics?
So I would like to really take some credit, but I really give credit where it's due. We have had a fantastic visionary founder, Dr. Sanjeev Blackenpole, who so early on saw really how to properly manage venous disease. And we saw what was going on from the phlebology side. And there was a vacuum of diagnosis management. But then he also saw the incredible need that these patients had for lymphatic care. And that was the drive to bring in the lymphedema therapists so early on and so far ahead of anybody else. Now we're seeing more over the years of this combined approach, but we're still very much a minority. And I want to just say thank you to Nicole Lawson. She's still very much active out there when she taught us how to design a protocol approach that continues to evolve, how to best manage these patients collaboratively that needed venous treatment as well as lymphatic therapy. So it really just came together slowly. It came because of need and lack of understanding and support in the community. But and obviously along the road found fantastic therapists who are willing to learn the way we do it. We're not saying we do it the right way, but I think what we're doing right now is in a very much of its infancy to something that will continue to evolve. And just like the LEAR project wants to come up with what perhaps are the proper international protocols and how we're going to collaboratively manage this for the greater good.
Yes, I love that. And it sounds, I mean, it's clear the two of you work well together, and there must have been a learning curve as you went through and educated patients. And what's that?
That's just good, but I don't know which way everybody slided it, so you're both.
So thank you again. That was wonderful. So the two of you will remain on and then come at the end for some of the Q&A from the audience or the attendees. So we'll move on now. We're going to be hearing from Hamilton Phlebolymphedema Program, and we're going to be hearing from Shauna Gordon, who's a PA, and Dr. Carlos Hamilton, and Christina Hankins, who's CLT. So we are going to learn about how they have collaborated and moved forward with their program. Welcome.
Hey guys.
Hi.
So I'm Carlos Hamilton, and I'm going to start us off here. I started at Hamilton Vascular in 2010. I'm an interventional radiologist, and I left a hospital-based practice to start my own outpatient practice. And I started treating a lot of the vein patients, and then anybody taking care of vein patients quickly learns that their edema is a really significant problem. So I started working with Christina in 2014 up in Round Rock, which is just outside of Austin. And we shared quite a few mutual patients, and really we both saw how beneficial it was to collaborate and work together treating these patients. And it's just kind of grown from there. Now Christina works in a couple of our clinics and really does a great job dealing with the swelling on these patients. And so I'll just turn it over to her.
Thank you. Yeah, so we have two different vein and lymph models that Dr. Hamilton and I came up with really over, it's been a process and it will continue to be a process. So the first model is really where I work in Round Rock and I rent a room from Hamilton Vascular. And while it was meant to be to create an integrative and vein treatment approach, it is. It definitely is, but it's still, we're still separate. It's my own business and then his own business, and we're separate. In 2019, so last year at AVLS, Dr. Hamilton and I reconnected, and I mean, we've been talking, but we had more opportunity to talk at the conference. And so we really decided that we wanted more integration between vein and lymphatic, and that's where we kind of came up with this idea of, he came up with the idea of me coming to Houston and trying to figure out a way to really integrate good, comprehensive, efficient, effective care for patients that have both vein and lymphatic disease. So I have to disclose before we move forward that the model we're going to discuss is just that. Me, Dr. Hamilton, Shauna, Megan, Chris, several MAs. It's truly a team that's working together to take care of these patients. And it's in its infancy as far as a program, and we're continuing to develop it. And so I think what you'll see is going to reflect that. It's just reality on top of or in the midst of a pandemic, right? Like a lot of moving parts. So you can go ahead and move to the next slide, please. Okay, and the second slide. Sorry, reset all that.
So at Hamilton Vascular, before we had any kind of dedicated lymphedema program within our clinic, our initial evaluation, of course, diagnostic ultrasound, patients with swelling, vein disease, we go ahead, treat their veins. We try to educate them that their swelling may not entirely be eliminated. And then after all of their vein treatment is complete, if they still have residual swelling, most of the time we were just referring out for a pneumatic compression device. If they had really severe stage 3 lymphedema or any wounds, then we're referring out to those appropriate specialists, either outpatient lymphedema therapy, which in the Houston area had a wait list of about 4 months to get a patient in for an initial evaluation. And then for wounds, we're sending to wound care. So for all of these problems that are all interrelated, these patients are seeing 3 different specialists, going to 3 different offices for all of their care. And next slide.
So, but before we move forward, so we feel like we're doing that different now, right?
So that's before. So now with the program, with Christina involved with our patients in the clinic, we're able to have these patients with swelling that we identify as lymphedema candidates to see her in our clinic after their diagnostic ultrasound, before their treatment, whenever it will fit in with what they have going on in their schedule. See Christina for an initial consultation. She comes up with a plan as far as the lymphedema side, and then we're able to do that along with their vein therapies in the clinic. So if they come in for ablations, then immediately after their ablation, she's got the plan listed, and myself and the other PAs in the clinic know how to do the bandaging now from her training. And so we're able to bandage those patients and do their lymphedema therapy along with their vein therapy all in the same visit, and they can get then that treatment done in a shorter amount of time, shorter visits, and that sort of thing.
Yeah. we'll add more to that, I think, as we move forward. It's a drastic change from really doing as much as you can from the vein side, but then what do we do with the resulting or the continued edema, and to wait 4 months for a patient to wait 4 months to get an eval, not even treatment, that's just you get an eval in 4 months. They fall off, or they have an infection, or they have wounds. And so I think that brings us, I think that was part of Dr. Hamilton's motivation to add a lymph program. I know for me, it's always a motivation to add a lymph program. But
yeah, so I mean, let me just add one thing. So it's not only is a lot more convenient for the patients, it's also a lot more effective. I think everybody that treats veins gets really frustrated with not every wound care place is like this, but we'll see patients who've been going to wound care 3 times a week for 6 months or 2 years or 3 years, and then they find us. And being able to offer wound care to our patients, not having to send them out, as well as being able to treat the lymphedema, because at least in Houston, there really aren't any places now that do both lymphedema and wound care at the same time. And so we've been able to make it a much more efficient and effective program for the patients.
So the motivations, I think, to add a lymph program, it makes sense. There's a lot of swelling that's out there. There is a lot of swelling. To differentiate between where the swelling comes from. Is it cardiac? Is it hepatic? Is it renal? Usually all of that is teased out, but I think right before they even come to vein, and if not, that you guys definitely go that route. And then they continue to have issues such as fibrosis and wounds and swelling, and it's a lot to manage where this edema comes from. So it makes sense to have more of a comprehensive program. Go ahead and. So things to think about when adding a phlebo lymphedema program. Well, scheduling pretty rough. I know Dr. Fernandez and then Geeta talked about this as well. It can be difficult, but in my experience of really working by myself in Round Rock, and then also working with a team, it is a lot easier. I think most lymph therapists, we can all attest to, we're like in the basement, onesie, twosie, that we don't have whole teams that we work with, and that's one, it's lonely, but two, it's a difficult. It is hardworking population to work with. Like, we have to work really hard to help these folks. And so to have a whole team that we can to schedule that's just huge. But yeah, it's something you got to think about to have that team. And then, as they mentioned, insurance and all of that. Yes, there's a lot of things to think about with that part, but not any different than you're already thinking about when you're trying to be approved for vein procedures. So it's just adding those next CPT codes in. I think it was so we're still trying to find a full-time lymph therapist for the Houston clinic, because I just come 1 day a week right now. And it's in the midst of a pandemic where people aren't getting certified. I think it's just starting to start back up. It's been hard, but it was hard even before that. And so, yep, gotta consider that. But you just keep plugging forward. Training all the staff, that I will say I train patients how to bandage and to work with PAs and MAs and physicians that really want to learn. It's been a great joy. I guess I'll ask you, what was your experience in learning how to bandage? I mean, Shauna does, Megan, Chris, all the PAs bandage, and they bandage the lymphedema way, which is foam and short stretch. So what?
Yeah, challenging to learn at first, certainly to take on a new skill, but Christina's a great teacher, and I think when you do it a couple of times, seeing these patients back, because we're seeing them back in the clinic 2-3 days a week to see the improvement that they get gives you the reassurance that you're doing it right and you're doing the right thing for them too.
Yeah, and then something other to think about is all the various products. So, you know, as a lymph therapist, I mean, I'm still learning as well. There's a lot of different products out there, but if, you know, there's not really one product that works for a patient. So we just have to do it. And just like anything else, learning can be difficult, but as you move through it, you get it. Like now, you know, there's all types of Velcro wraps, all types of short stretch, various rolled knit. It's a work in progress, and I really see everybody stepping up and understanding it's possible. Yeah. The cost of supplies, that's different for, I think, the PAs to talk to patients about cost of supplies. This is something that's very, I've as a lymph therapist, I grew up having to talk to patients about the cost of their supplies, and then the cost, how much the garments cost. All of that is, it's a personal conversation, but it's necessary. They cannot make any movement forward without having the supplies, both bandages and garments. So
Right.
they're doing it. Go ahead and forward. So I really feel like considerations, barriers, and challenges, they just really, all of those things that I just listed could be a barrier. You could say that's way too much to think about, so I'm just not going to deal with it. I look at it as challenges. I feel like Dr. Hamilton and all the staff also look at it as challenges. And so that to me means we just have to problem solve and figure these things out. And we are, I won't say that it's not without, you know, some blood, sweat, and I don't know, tears really, but definitely blood and sweat.
Mostly sweat.
Mostly sweat, yeah. We try to limit the blood. So go ahead and move it forward, because I feel like we covered that.
Yeah.
Okay. All right, so because I know there's tons of advantages to having a lymph program, I'm going to ask Shauna to talk about the advantages.
So as I said in the previous presentation, it's the patient outcomes and the satisfaction that they get. People who have had swelling, chronic swelling, and it's been a hindrance to their quality of life, to be able to put them through this program that's 2, 3, 4 weeks long and give them the patient and see the difference it makes for them. That's definitely the best advantage. From more of a business standpoint, you know, certainly being able to add this in as something that we offer as a practice. These patients go back to their primary doctors and can show them the improvement in swelling that they've gotten, and then that can continue to keep the referral pool going. And then certainly the lasting results that we get from being able to hear from Christina, from me, from Dr. Hamilton, the medical assistants, of what this process is that's going on with them and how to control it. I think we get better outcomes long term when they really understand what's going on with their body, and then in turn what they need to do to fix that, and the part of it that they have to do themselves. And then certainly for us PAs, being able to bandage and the things that the medical assistants are learning, just to have another skill that we have under our belt is an advantage too.
Mm-hmm.
So I think, you know, for me, I think the advantage, because I have this kind of control group in Round Rock where I am in a vascular center, but we're still separate. I honestly feel like as hard as we all work in Round Rock, and we are in trying to describe the disease process and help patients to understand that, to understand their disease process, I honestly feel like our patients out of Houston are coming out with a higher level of the understanding of their own disease process in a way that I haven't seen before. And I really do think it's because touch point with Megan, touch point with Dr. Hamilton, touch point with Shauna, touch point with the MA, it's all in one appointment, and they're just hearing it back to back to back to back, and they can't wiggle out and say, I've been in denial of this for so long. Doctor over here said this, doctor right here is saying you have lymphedema and this is how we're going to treat it, and you have to manage it. So, but to me, and of course, outcomes and satisfaction makes Like, that's really why I kept in working with lymph patients, but having this experience, biggest advantage is I see patients really understanding their disease process better. Okay, go ahead and move to the next.
All right, so on this first patient, this is when I saw a year or so ago, and this patient has had all the superficial veins have been treated, and there was really just nothing left. He had really bad lipodermatosclerosis, a wound on his right medial malleolus, and just really kind of severe pain. He could not, he usually would exercise 5 days a week, couldn't do that, couldn't work. It was very painful for him to walk. So at any rate, I told him I did not have anything to offer left on veins, and then that really the only thing that I could offer him is to see Christina. I knew I couldn't get him in to see a lymphedema therapist in Houston in less than 4 months, and I said, listen, the only thing that I think is really going to help you is to see a lymphedema therapist. So he actually drove 3 hours to Austin to see Christina, and so she started seeing him and working with him and explaining everything. One of the things I think about this is Christina will talk about the results, but to me, this is a typical lymphedema patient. It's usually the big swollen legs, and what do we do with that? But he's responded really, really well to treatment. So go ahead, Christina.
Go ahead and move to the next slide. So yeah, I agree. I mean, to have these really misshapen large legs is more typical for a lymphedema referral. To see somebody like this, I also see as very severe. He was very fibrotic, very hard, non-pitting edema. And yes, that is the lipodermatosclerosis, but it also that is the scarring of all of that tissue, including lymphatics, which gives you lymphatic insufficiency. And so I think these patients get missed from or don't get referred for lymphedema, and they should. So I like this. I love this example in that he came, I evaluated him, I started him right away on self-MLD, self-bandaging. His wife came with him, and some basic exercises. He hobbled in, it was 100 feet. He hobbled into my office and told me, I exercise, I work, I fly. I have not done any of this in the past 2 months, is what he was saying. So I followed up with him a couple weeks later, actually in Houston, and he was bandaging, doing his self-massage. Pain was decreasing. He was able to get back to some exercise and walk much better. Go ahead and forward to the next slide. And I'm really apologetic. I would have loved to have more of that medial view, because it just, the hyperkeratosis, the lynchinification, all of that just was so much better. We did treat using MLD and bandaging and exercise, but I also did have to debride some of that hyperkeratosis. There wasn't any wound under there, but I did have to take that tough, dry skin off. But 5 weeks, he was able, no pain, returned back to work, returned back to exercise, and was discharged with a flat knit knee high. And that's something that I have realized the vein world really doesn't use much. I'm sure there are some physicians that do, but that is something that I think that this conference can help to propel that education of how important the lymphedema type products are when treating patients that have phlebolymphedema. So we have another case study, and Shauna's going to go through that. Go ahead.
The next slide. So this patient is a 62-year-old African-American male, had a history of a traumatic injury to his right leg. He had a lot of orthopedic surgeries, subsequent infections, debridements, back and forth. So he was left with this extremely scarred and swollen leg. You can also see he's got some hyperpigmentation and LDS toward the medial aspect of that right calf as well. So he was actually sent to our clinic specifically for his swelling. A diagnostic ultrasound determined he did have superficial vein reflux. You can see his left leg had some swelling in it as well. Obviously not as severe as what he has going on with the right. But based on the level of swelling he had, I also wanted him to see Christina, so was referred to Christina within our own clinic. He saw her. We gave him the rundown of all the vein treatments that he would need, and Christina went through what all of his lymphedema therapy side would look like. He was very skeptical about any of the system. His leg had looked like this for 15 years. No one had ever mentioned anything to him about lymphedema. They'd always just told him to wear a generic knee-high compression stocking so it wouldn't get worse, but it never looked any better from that point. So after multiple calls over the phone, reviewing all of this with him, he finally scheduled for vein treatment and lymphedema treatment as well. And we can go to the next slide. So after a phase of his bilateral great and small saphenous veins, a little bit of erythema for some residual varicosities, we're bandaging him all at the same time. So after his RFA appointments, right after we're done cleaning the patient and everything, getting the incision all dressed, then we were going in and bandaging with 1/4-inch foam and short stretch bandages. He came in initially 3 times per week. After the first week, this is the difference that we got. We did convince him to actually go ahead with both legs at the same time, and already we're starting to see reduction in size on the left as well. And then next slide. Then after just 3 weeks of bandaging, the patient was walking better. He was, like Christina's case before, was hobbling into our clinic the first time that he came in. He was walking so much better. Said his leg hadn't looked that good in 15 years. We were able to fit him for some ready wrap garments with the Velcro at first, which with his lifestyle and his work were a little bit bulky for him. So he ended up getting custom flat knits made and shipped, which took another 2 weeks to come in, but he was willing to wait for that and maintain his swelling and this decreased level to get in the flat knits, which are much more low profile and more conducive to his lifestyle. And then next slide will show the before and after side by side, and you can see what a difference, how much more uniform in shape his right leg is on the after compared to before. Even his left leg, how much improvement he had in his swelling. And he was so happy. He was finally a believer in what we were doing after the first week seeing a difference. His was a really drastic case and really good outcome. And that's what keeps me wanting to do this and keep learning from Christina and continue to do this for our patients, to see huge differences like this multiple times a day.
Go ahead and move forward to the next. So, given all the challenges, is it worth it? And is it worth it?
Yeah, without a doubt, it's worth it. Just to see people like the guy before, or just all of our patients have gotten really good reduction in their swelling and have all been so much happier than I know they could have been, because I know how we were doing it before, how much swelling they would have after just treating the veins. And we don't have those, but my leg's still swollen now. And what do you do? Why did I do all of this if my swelling's not better? So now we're able to give them a comprehensive place, one stop to have all of this accomplished and treat their whole system and not just one piece of it.
You feel like it's worth it?
Yeah. I do feel like it's worth it. One, it's great for the patient care, but another thing that's really great about this is that these patients have all been to multiple other doctors before. They've been told to take diuretics, wear a stocking, which just rarely is adequate. And they're disappointed. They find us one way or the other, and then we're able to really, with Christina's help and everybody working together, fix their swelling, fix their veins. They're very happy. They're your best advocates when they go back to their physician and they tell them that, they fixed my swelling and I've been coming here for 10 years and, you haven't really known what to do. And so being able to do that is really huge. And then referring physicians, swelling is a big problem for them. It's really just a headache for them. They don't have any good solutions. And for them to be able to send us patients with a primary reason of leg swelling and be able to take care of those patients, it's really a great thing to be able to offer.
Wow, thank you. Thank you so much. I think, if you were on the session before, Dr. Gasparis said, hey, Steve, can we take this on the road? I think this is something that should really be taken on the road, because there aren't enough doctors that work at vein specialists that know how much of a improvement and how much better the outcomes for the patients can be. And I think what I heard from both groups, whether it is a CLT working within a clinic or like you, Christine, who is independent but overseeing and educating staff, both groups really talked about patient satisfaction, improved patient outcome, increased referrals. I really feel that you all do such a great job. And if we could bring the other two on just for a few minutes, I know we have about 5 minutes for a few questions. And I think one of my questions is probably for the CLTs is there are a lot of lymphedema therapists that don't know how to get something like this going with their vein practices in their area. So what would you say to them about how to approach a vascular clinic, or what is the best way to go about that? Geeta, do you want to say anything, or?
Sure. I would recommend that they do visit them, educate them during like events like this are the best way to convey that information to them and share their skills, visit them, or like, let's say, for example, I have a patient referred from a vein specialist. I would like to reach out to them and show them how much the patient has improved so that I can discuss the importance and how collaborating together we can have a better outcome for this patient.
Yeah.
I would definitely
go on. Yeah, yes, go ahead, doctor.
No, because she brings to a very, reach out to the venous specialists that are referring to you. We really want to hear back from you. That is a benefit that we get immediately from having Geeta within our team. We're in a constant collaborative environment, not just seeing her notes, but able to pick up the phone and talk to her about a specific patient. We don't have that same level of communication from other lymphedema therapists that we might need to use geographically because they cannot travel to Geeta. We need to use somebody outside of our umbrella. And we just don't get that same feedback. So do reach out to your venous specialists. Don't be fearful. We're all in this together. We recognize the need. We want this for our patients. So if you are trying to work either with the vein clinic collaboratively, that's easy. Really, if you reach out, we want to hear very much from you.
Thank you for that suggestion. I do have one that came up in your presentation, Dr. Fernandez, and that was how many lymphedema patients as a percentage could benefit from stents. Do you have an answer for that?
I don't have that. I don't think that we have a full data on that. That is something that continues to evolve with better diagnostics. Right now, the data that we've been using to identify these patients, whether it was MRV, CTVs, Dr. Hamilton would attest to this, it's very dependent upon the technologist performing that as well as the radiologist reading and their experience with it. We have shifted towards more of a screening process with sonography, external sonography, and then based on the patient's clinical presentation, those findings, doing something more of the traditional venogram and IVUS. But right now, in terms of what really percentage of lymphedema patients have venous compression as their initial etiology, I don't think that we have good data. I think we're still missing a lot. I think a lot of patients get diagnosed with lymphedema, whether it's primary, secondary, and nobody has ever looked into their pelvic region first. My rule as a clinician is to always try and find the etiology of that lymphedema. If it's not venous, whether they had trauma, infections, family history, and if I can't really come up with something that is clear cut as an incident, I always want to exclude pelvic. So I think that if you have a patient in which the history is not supporting why they have developed lymphedema, you owe it to the patient to find the etiology, because otherwise you just might be treating one of the components. Again, I discussed, that sort of nice junction that exists between the three systems, and we're ignoring one critical component of that.
Okay.
I'll let Dr. Hamilton, if he wants to, also pitch
Yeah,
in.
do you want to comment on that at all, Dr. Hamilton? Or?
No, I agree. I agree with Dr. Fernandez on that. The question is tense. I'll tell you another thing that I think is missing when it talk about integrating lymphedema with vein centers is that, you know, so far I just kind of hear like when the vein centers send patients to the lymphedema therapists. And, you know, there's really just no reason that lymphedema therapists cannot send patients to a vein center. It's a very straightforward thing. If you start sending patients to someone, they're going to listen to you, and they're going to want to, you know, then all of a sudden they're going to be, oh, wait, you have these patients I can work with, and that's going to foster collaboration. So, you know, waiting for someone to send to a lymphedema person, if a lymphedema therapist wants to get involved with a vein center, send them a patient. I mean, one thing I've heard, though, a lot of times is lymphedema therapists will say, well, treating the veins is going to make them worse, which hadn't really been our experience. But, you know, if they have vein patients, send them to the vein doctor and they'll listen to you.
I think that there's a lot of education that needs to happen on, you know, lymphedema therapists as well as, and I think I see that in your practices as well, that you really learn from each other in how we're going to get the best outcomes. I have one more question because it is 8:01, and this one was for Dr. Fernandez regarding case number 1. Would you have the patient see Gita or the therapist sooner after the intervention moving forward, or still want to wait a period of time such as 6 months before lymphedema therapy? And I think that just brings up a question of, for probably all of you, you know, how are you determining the time between your interventions and then starting lymphedema treatment?
So once this patient, so because we have sort of this triple connection between our peripheral venous side, our deep venous side, and our lymphatic side, once that patient went towards the deep, they sort of control that follow-up, and that's how they determine that follow-up. So it is sort of, there's no clear-cut science. We usually get the lymphedema started as soon as within a month of treatment, if not before. And it varies from patient to patient and also clinician to clinician. But we do encourage those to be identified as early as possible, to start it as early as possible. But that case in particular was managed from that deep venous side.
Okay. Did you want to add anything in terms of time, Dr. Hamilton, from?
Yeah, I would. So one thing that I find really helpful, especially having Christina and also the PAs that are knowledgeable about lymphedema, is if I see somebody with significant swelling on a vein consult, even if it's before their diagnostic ultrasound, I will try to get them to talk to Christina as soon as possible. If someone has mild edema and I think it might get better enough, then I'll kind of wait, but I'll go, well, we may need to deal with your swelling later. But boy, swelling is the biggest complaint that we have. The sooner that I can get somebody to see Christina and address it directly, the better. And hey, if all the swelling goes well with the vein treatments, that's super, but that is really a rare thing. And so being able to pass them off, I mean, the same day as a consult is great with me. So.
Yeah, and you got a very valid point, Dr. Hamilton, and that is something key too, to understand that if from the phlebology side, if we have somebody with a very advanced sort of phlebolympedema picture, you might do better by decongesting them first. And some patients do go that route. So there is, again, not a perfect answer to, or a standardized answer yet, because it's very much on the clinician. But some of these patients with very severe dermatitis and lymphorrhea already present, they might really benefit better from that active initial decongestive therapy, and then proceed with any venous therapy where that skin is healthier and might be able to, you're going to lower the risk of any complications such as infection for that patient.
That is a great point. So we are at 8:05, and I appreciate all of you spending your time with us tonight, and such great presentations Thank you so much.
Thank you.
All right.
Thank you.
Thank you. Have a great night, everybody.
Yeah, you too.
Thank you.
Bye.
Bye.